at ETSU and received her PhD from the University of Memphis.
Correct.
She's going to be speaking with us today. Please, for the residents, remember to do the barcode and then the evaluation, so just remember that you're signing in. Thank you very much.
Yes. All right. Thanks so much. Do I have to? Is this? I still have to flip it. Okay. Oh my goodness. So yeah. Okay. You guys can hear me. All right. So thank you for that introduction. So my name is Meridith Ginley, and I'm going to be presenting today on my program of research, which at its broadest level is focused on the etiological and change mechanisms of addiction. How many people in this room work with patients with addiction? Okay, so that's a good percentage. All right. All right. So I have no conflict of interest to disclose. All right. So one of the major mechanisms and risk factors I've focused my program of research on is impulsivity. And impulsivity has been shown to be highly corresponding with a lot of risk factors and a lot of risk behaviors. So things from addiction, high-risk sexual behaviors, even things that increase your risk and chances for morbidity and mortality, as well as antisocial behaviors such as engaging in criminal activity. And I'm going to be presenting 3 studies today, which are going to focus on that interest in impulsivity and how it relates to high-risk behaviors. So I'm presenting first on the background related to impulsivity and a bit about some background on gambling disorder. And how those 2 topics, so both impulsivity and gambling, are of particular salience when you're talking about college student populations or that transition age youth emerging adult sample. The first study I'll be presenting is looking at a multidimensional model of impulsivity as it corresponds to gambling behavior. And this was a model that was found in the addiction literature, substance use addiction literature, that's been translated over. The next study will take that model of impulsivity and show how it corresponds with outcome expectancies for engagement in risk behavior of gambling. And the final study is going to take a look at applying my interest in impulsivity to a sample of individuals who are among the most impulsive I've ever worked with, and that's individuals who are on methadone maintenance treatment, also with co-occurring cocaine use disorders, and who have recently been engaging in illegal activity, and showing how we can look at how impulsivity makes sense for that. And during that study, I'll talk a bit about medication-assisted treatment, as well as contingency management treatment. All right, so let's first talk about gambling. So gambling is when anytime you bet money or something you value on an event where the outcome is unknown. And gambling is pretty common and pretty prevalent in the US. We estimate that about 80% of individuals in the US will have gambled at some point within their lifetime. And gambling culture is incredibly pervasive. I bet if I surveyed everyone in this room right now, you've all thought about what you would do if you were to buy the lottery, maybe the first thing you would buy. And you maybe never even buy a ticket. It's still, we just talk about winning and gambling in that type of way. And gambling has been around in the US for a very long time. In fact, pre-United States, there was lotteries run to help finance the Revolutionary War. So we've been gambling in this country since before it even started. And depending on historical times, there's been kind of more gambling legalized and less gambling legalized, similar to patterns you see with substance being legalized. And gambling happens in many forms. The most commonly engaged in form of gambling is lottery-based gambling. That's about 60% of the gambling that happens. And that's currently the main form of legalized gambling we actually have in Tennessee. There's no casinos here, although you can get to them very quickly. And there's plenty of illegal gambling that's also happening here. All right, and gambling happens across a continuum. So most people gamble just for fun. They do so recreationally. They never have any problems related to their gambling. They're those people that pick up the lottery ticket when the Powerball hits $325 million, and it's just too hard to resist and spend $10 a couple times a year. As well as there's also that 20% of the population that never ever gambles. The people we worry about is this small group that's considered either a problematic gambler or an individual who meets criteria for gambling disorder. So problematic gamblers represent about 2% of the population. That's a lifetime diagnosis, and about 1% will meet criteria for gambling disorder at some point during their lifetime. Gambling is actually in a kind of cool spot right now, and this is, I guess this change happened 5 years ago, but we're still getting used to it. It used to be considered an impulse control disorder. Now it's actually classified under the new DSM-5 category of addictive disorders, which can include behavioral addictions. So it's sort of the flagship behavioral addictions by which we will measure all other behaviors to determine if they actually are true bona fide addictions. These are the criteria that you must meet in order to get a gambling disorder diagnosis. And they fall across 4 broad domains of withdrawal, harm, tolerance, and risk. And you have to have 4 of these symptoms in order to get the gambling disorder diagnosis. So it's a higher threshold. For substance use disorder, you just have to have 2. So we do mark a bit higher still for gambling. When we look at problem rates, we use the criteria of 3 or more generally. That's kind of that midpoint compromise between the substance use criteria and the 4 that they're requiring for the DSM diagnosis. National prevalence estimates, as you'll see, they peak, they do vary across the lifespan, but you also sort of see that onset of when problems start to peak is right around when gambling becomes legal for most people. So that's age 18. For college students, however, this most recent meta-analysis by Nowak and Allo, which was completed in 2015, suggests that while the general national prevalence rates was about 3%, college students, about 10% of them are experiencing at least 3 or more adverse consequences for them in their gambling. And national prevalence estimates for the adult population have stayed really consistent over the past couple decades. We've gotten a whole lot more casinos, we've legalized a lot more gambling, but we're still seeing that the rates are staying pretty stable. College students, when they did this meta-analysis in 1999, it was 5% that were having difficulties. They redid it in 2007, and they saw 8% with difficulties. Redid it in 2015, now we're at 10%. So there's something happening with college students where they're gambling at higher rates and experiencing more adverse symptoms. There's all sorts of guesses. I'm sure you guys have guesses about what that could be. Probably the online gambling becoming very prevalent, and the fact that you can gamble on your iPhone 24/7, which college students are very connected to, might be very well part of that. All right. College students who gamble have a range of adverse consequences. So they can have a decrease in their academic performance. This behavior can be socially and physically isolating. It can lead to debt and bankruptcy. These people are mostly on pretty fixed incomes with pretty high expenses related to their educations. So you don't have a whole lot of spending cushion when you're a college student. Relationship difficulties, increased risk for suicide, alcohol abuse, substance use disorders, as well as high correspondence with major depressive disorders, generalized anxiety disorders, phobias, panic, all those fun anxiety disorders. So why do we think that college students are gambling at a higher rate? So it's likely that impulsivity and cortical immaturity is part of that story. So research evidence suggests that individuals, that part of the brain that's responsible for the frontal lobe area, that's responsible for regulation of your emotions and impulsivity, that doesn't finish until you're in your mid-20s, at least into your 20s. So that maps right onto when college students are starting to gamble. And this also corresponds with self-reported impulsivity findings, where we don't see that dip in impulsivity until after age 25. So if you see right with the college students, they're still very much in range of high risk, high impulsivity behavior, even of younger children. And it's not until after 25 that your impulsivity starts to reduce down. So overall, meta-analyses seem to support that impulsivity has been driving the higher than expected rates of gambling and high-risk behaviors in college student populations. However, with impulsivity specifically tied to gambling, they initially were looking at it using a range of single-dimensional concepts of impulsivity, and sometimes the results were actually coming out that people were less impulsive where gamblers were less impulsive than individuals who were with other substance use disorders or whatnot, or that they were equally impulsive. And the likely reason why that was is because of those single unitary dimensions of impulsivity that were being measured. So a multidimensional approach to impulsivity has received wide theoretical support, but it hadn't yet been explored in gambling, and it had been limited to other addictive behaviors. And the idea that there's different types of impulsivity that have different relations to high-risk behaviors like gambling. So it's probably a different thing that makes you want to start gambling, makes you continue to gamble despite the fact that you're losing, and makes you keep going back to the casino even if you are in large debts now from your behavior. It's likely very different things. It's not all the same thing that got you to start. All right. So this is the model of impulsivity that I was interested in looking at. And this model was initially validated by Maida and colleagues in a sample of individuals who were either at risk for addiction based on their family history. They had current addictive disorders, either stimulant use disorder or alcohol use disorders, or were healthy controls. And they completed this large battery of impulsivity measures with all these patients. And the measures that they selected were based off of things that they thought would correspond with biomarkers of addictive behaviors. So they were trying to isolate specific factors of impulsivity that then would maybe tie to something within the brain that would help them explain impulsivity within this sample. So the measures that they used, that was the appeal of that perhaps biological basis to their measures, and then also several of the individual measures that they had selected had also been independently shown to correspond with gambling in college students or adult samples. So I was interested in seeing if this particular model would perhaps be the one that would help explain gambling. All right, so what are those factors? So behavioral activation is this idea of, this is almost your brain's interest. If you were thinking like the fMRI scan kind of images, the brain lighting up when you're exposed to high risk type of behaviors. It stops short of actually measuring behavioral engagement. So people will score high on behavioral activation. It's a self-report measure, but they may actually not engage in the most risky behaviors when you actually follow them around on a day-to-day basis. So it's kind of this interesting, it's like your perception of yourself as an impulsive person. Preference for stimulation, that's your kind of like prototypical impulsive behavior. So that's I want to go jump off the cliff, I'm going to go skydiving, I love doing high sensation risky things. When we think of impulsivity kind of as a colloquial term, that's preference for stimulation. And this last one, insensitivity to punishment, is this idea that there's people who are able to accurately appraise that something might be a risk behavior, and then they still go out and do it anyway. So they are your patient who sits in front of you and has this whole discussion about how continuing to engage in this substance use is going to, put them back in jail. And then they are walking home, they run into their drug dealer at CVS and they buy drugs. So they can totally articulate, but they still fail to inhibit that behavior. So those are the three dimensions that were hypothesized could be present. So this was the paper. Right. So the first study was looking at if this model that had explained the addictive behavior in Maida's sample of substance use addicted patients would explain gambling behavior in college students. So we were trying to replicate that factor structure and determine how the dimensions would correspond to gambling risk specifically. Hypotheses were that all three factors of impulsivity would be higher in individuals who are gambling. We recruited from 3 different sites. So it was a large urban university in the Mid-South, a large university in the Northeast, and a small college in the Northeast. We capped age participation at 25 because of that dip in impulsivity that you see that we wouldn't be able to control for. A little over 50% female, a little over 50% Caucasian. And this maps on pretty closely to the college students that were in these universities. It's not totally representative of college students across the country. Gave them a whole battery of questionnaires. Those top ones are the gambling-related symptom measures. The bottom ones are the impulsivity measures. I can answer questions later if you guys are interested in the measures specifically. Gambling behavior. So 36% were non-gamblers, which is higher than we would have expected since we think about 80% of them are gambling in the past year. But the symptomatic gamblers, 9%, that maps closely on to the 10% that we expected to see. So it's likely a sample that's pretty representative of what college students who gamble, college students that look like in general. So we replicated the exact principal components analysis procedure that Mehta and his coworkers had completed. Extracted 3 factors, accounted for about 63% of the variance for the behavior. Found the model to be an adequate fit for the data, and it did significantly correspond with both gambling frequency and symptoms. All right, so let me orient you to this chart. So we've got the factors are the bottom, across the bottom, and then how impulsive people are. So here, lower is like worse, so more impulsive. Lower is better. Lower is better on this one. You've got green is your non-gamblers, purple is your low-risk gamblers, and blue is your symptomatic gamblers. So here we found that behavioral activation was significantly different between the gamblers and the non-gamblers, with the symptomatic gamblers reporting the highest levels of behavioral activation. Preference for stimulation, again, mirrored what had been found in the addictive disorder sample, and this tracks onto most conventional data around impulsivity, higher impulsivity in those with symptomatic addictive behavior. And then insensitivity to punishment was an interesting finding because there wasn't actually a difference between the low risk and the symptomatic gamblers here. The difference was between those who had never gambled and those who had gambled. So perhaps there's something going on here where being sensitive to punishment actually makes you just never, ever go out and gamble if you're a college student. So, all right, so we found promisingly that those 3 dimensions that had been developed and tested within that substance use addiction sample had replicated within the behavioral addiction sample that was also a college student sample instead of a general adult sample, and that those factors were significantly and differentially related to gambling classification. Obviously, lots of limitations to this study. So we had relatively low rates of gambling compared to what we would have expected population samples. It was a cross-sectional sample, so we're not able to draw any conclusions about if these high levels of impulsivity predict engagement in gambling behavior. It's just we see people who are gambling and people who have high impulsivity, that's what they look like together. We don't know what comes first. Only use self-reported rates of impulsivity. We didn't follow them around and see if they were actually engaging in these high-risk behaviors. And we don't know what else accounts for the link between impulsivity and gambling. It's likely a much more complicated story than just impulsivity leads to. So that leads to the second study, which is the idea of this one was to try to answer at least some of the story of what else might be related. So this is a model by Patterson and Newman, which is called the acquired preparedness model. And the basis behind this model is that individuals have this kind of like pre-existing propensity towards impulsivity. And then they go out into the world and they start engaging in behaviors. And they learn about those behaviors by their experience. And if you're an impulsive person, you are more likely to remember the good things about an experience and more likely to go out and engage in that behavior again. Whereas if you're a less impulsive person, you might remember more of a neutral experience if things were actually neutral. You have more accurate appraisal. So you actually, if you're impulsive, you're more likely to be thinking things would have positive outcomes and more likely to, regardless of what happened when you actually went out and did it, remember a positive experience. Expectancy theories on their own have been around for a really long time. We've often been interested in how what people think about what they do relates to whether or not they actually engage. And they're of particular clinical utility because they've actually found that we can modify individuals' expectancies about behavior in order to change whether or not they're going to go out and do it. So if we can teach them that something they think looks really cool and fun actually isn't, they may be less likely. So to break this down further, put this in practical terms for all of us. So People who are more impulsive, they're more likely to when they see the cookies that are on the tray, they're more likely to think about all the good things about cookies, think about how fun it is to eat a whole bunch of cookies, remember how tasty they were, how much fun they were having the last time they ate a whole bunch of cookies, and they're more likely to engage in the cookie binge. Whereas people who are lower on impulsivity, they are more likely to be able to remember, last time I ate a whole bunch of cookies, I felt really sick. The next weigh-in I went into was really not what I was hoping for. And they are less likely to re-engage in that binge. So it's our impulsivity that relates to, in some way, to how we remember events and how we appraise our future engagement. So with gambling, we have impulsivity, and then the positive expectancies about gambling are things like I'm going to win money, I'm more likely to be able to have a really fun time with my friends, it's just going to be an awesome night out at the casino. Whereas negative expectancies about gambling are things like I'm going to lose money, my parents are going to be so mad at me, I'm not going to be able to make my car payment this month, those type of expectancies. And even within this sample, a lot of them had expectancies that if they were to engage in gambling, they may actually have legal repercussions and could get mixed up in a dangerous situation or have contact with the police, probably reflecting that there was some illegal gambling going on with college students. All right, so the acquired preparedness model previously had never been tested with gambling, and they had always looked at it as a single dimension of impulsivity. So that preference for stimulation factor, that more conventional impulsivity, to see how it would relate to expectancies. And the acquired preparedness model has been validated for a range of addictive behaviors. So smoking initiation, alcohol use, substance use, bulimic eating behaviors, and high-risk sexual behavior. So with gambling, we wanted to not only see if the model would explain gambling behavior, but we also wanted to see if by specifically breaking down impulsivity into these three different dimensions, if those dimensions would significantly and differentially relate to gambling, and maybe give us even more explanation of what was going on. So the same sample as the participants in study 1, these people also got, this is the addition of this expectancy measure for college student gambling. Overall, the model was found to be a good fit for the data, so the acquired preparedness model does explain gambling behavior. Then looking at the specific factors, so behavioral activation, as it relates to the expectancies, it actually really didn't give us much information at all. It's kind of people's perception of what's going on. It may not actually correspond to real action. We need some more work figuring out behavioral activation. Preference for stimulation, so this is your conventional impulsivity, let's go do crazy things. And then I expect gambling will be a really fun, awesome time. That leads to more frequent gambling. So that one's like, okay, yeah, obvious, that makes sense. And then this one is my favorite. So this is the idea that if you're insensitive to punishment, so you can say, all right, I recognize bad things might happen, but I'm probably gonna do it anyway. These people are still expecting bad things to happen, and they can articulate that bad things might happen if they gamble, and they're still gambling more often. So it's almost like the proof of the concept for insensitivity punishment is that these are people that are able to say, bad things might happen if I gamble, but they're still gambling more often. All right. So overall, we found that acquired preparedness model, so this was another model that was developed initially in the substance use addiction literature that has been replicated in the behavioral addiction literature, and that corresponded with gambling behavior, and that also that those three impulsivity factors, so using three factors instead of just lumping everything together, did give us additional explanatory value of behavior. Still limitations, of course, all these studies have lots of limitations, but it was cross-sectional data. So all tests of the acquired preparedness model actually to date have been cross-sectional. The Patterson and Newman model actually is kind of built into it is that impulsivity is kind of this trait-based thing that you have before you ever get exposed to behavior. So they don't mind that it's cross-sectional with their model, but it's gonna be really important to actually do that longitudinally because that's never been tested officially. Low gambling symptomology rates, so we ended up just looking at frequency because there wasn't enough people to look specifically at the behavior. And there may have been cohort-specific expectancies. So the fact that this sample was reporting high rates of risk behaviors that they could get it could be dangerous to gamble, that type of thing. That likely won't be replicated in other samples. This is the large majority of participants in this were from Memphis, where there's a lot of illegal gambling within the young adult transition age youth population. All right, so far just kind of circling us back. We have this multidimensional model of impulsivity that was developed in the substance use addiction literature that was found to significantly differentially correspond with behavioral addiction gambling. And that this multidimensional model significantly and differentially predicted expectancies for engagement in gambling. All right, so this brings us to our last study. So was interested in kind of translating this idea of impulsivity to a sample of individuals who are treatment seeking and in treatment, and seeing how that might relate to sort of how predictions go. So this sample is, I don't know if anyone's ever worked with individuals on methadone treatment with co-occurring stimulant use disorders. We don't even really measure impulsivity in this sample because they're at the top of all of our measures. We don't have good sense, they ceiling out, and we don't have good sensitivity up there. And they also don't really like doing large batteries of assessments. So anything that's not gonna be super predictive, we don't actually put those measures in if possible. And I'm talking about cocaine use. So this is a sample up in New England, and they do cocaine up there. Down here, it's meth instead of cocaine. You can pretty much interchange cocaine for meth in a lot of these clinical trials. They look very similar. They've done, the patients and the outcomes do look pretty similar. So for a proxy for impulsivity in this study, we looked at illegal activity. So a high impulsive act of engaging in an illegal act is sort of our proxy for impulsivity. I was really thinking about sort of how things connect. All right, so knowing that impulsivity is common can be helpful for treatment recommendations. So we're looking at methadone maintenance treatment. So just a little bit about methadone maintenance treatment. I'm guessing most of you are all familiar, but for those in the room that may not. So methadone maintenance treatment is for prevention and treatment of opioid use disorders. Methadone is an opioid agonist, and the idea is that it blocks receptors in the brain that would otherwise be able to take advantage of a drug like heroin. And it suppresses cravings, helps prevent withdrawal symptoms, and that specifically that craving mechanism is one of the kind of impulsivity targets that we think of. So craving, it's sort of an urge-based need to go out and get. So that may be the target of impulsivity. So methadone maintenance is a useful treatment for the treatment of opioid use disorders, but it is not effective for the treatment of stimulant use disorders that are co-occurring in this population. One treatment that is very, very effective for stimulant use disorders is contingency management. So this is an operant, contingency management is a treatment based on operant conditioning. So with contingency management, what you do is you are giving people a reward or an incentive in exchange for some specific desired behavior. So in the sample that I'm going to talk about, the study, what we're doing is we're giving people a reinforcement for providing urine toxicology samples that are negative for cocaine. And this is this treatment model is one that is tied to treatments we use for developmental disorders, autism spectrum. I think if you can think back to like elementary school, grade school, did anyone ever have like their teachers gave you like stickers or stars or checks for like giving your homework in and stuff like that? Okay, yeah, no, I know mine did. And then you get your prize at the end of the week that you can trade in for how many stickers you got. That's contingency management. It's a token economy kind of based system. So you do something, we give you a reward for it. So it's directly tied to whatever the behavior we're trying to reinforce. So here it's abstinence. So this project is a secondary data analysis. So it's combining 4 clinical trials. These clinical trials were specifically designed to target and explore the effectiveness of contingency management compared to standard care alone for individuals in methadone maintenance treatment with co-occurring substance use disorders. All right, so Methadone maintenance is very, very effective at reducing opioid use. And it's also been shown to be effective at reducing corresponding illegal activity. So the thought is that by pulling people sort of out of the situations where they're buying heroin, illicit opioids, they're no longer kind of in those environments where they're more in need of taking care of engaging in illegal activity. Despite the effectiveness of methadone treatment for treating opioid use disorders, we still see high rates of stimulant use disorders, cocaine use disorder. So about 40 to 60% of individuals in methadone treatment have that co-occurring diagnosis. So we use contingency management as an add-on treatment for that specific additional disorder. All right, so we hypothesized that contingency management treatment would reduce cocaine use and illegal activity above and beyond standard care treatment. We were able to make this hypothesis because contingency management has been shown to be a pretty robust predictor of outcomes across a range of different populations. Sort of no matter which kind of subgroup of population that you look at, we tend to see contingency management do better. So we guessed that perhaps they would do better even if they'd engaged in illegal activity. We hypothesized the reduction in illegal activity because, again, if you can reduce the cocaine use, maybe they're again kind of withdrawing even further from those circles where they would maybe be wanting to engage in illicit activity in order to continue use. All right, so samples. So all of these participants were recruited directly from the methadone clinics. They were actually, the research assistants were embedded within the methadone clinics. So participants didn't have to seek out directly to engage in the study. They just could kind of be getting their dose and they could go over and do their research participation. About 26% of the sample had reported engaging in an illegal act within the 30 days prior to the start of their research participation. So pretty decent rate of people still engaging in illegal activity, even while in treatment. Mostly male, mostly minority sample, and mean age about 38, which is pretty typical of what we see in the methadone population up in New England. I'm not sure how exactly that corresponds with down here. All right. So all participants were randomly assigned to either standard care or standard care plus contingency management treatment. Standard care treatment, what that looked like was daily methadone dosing at the methadone clinic. They got regular counseling from providers at that methadone clinic, and then they also got random drug testing. As part of the standard care for the research trial, they also got drug testing by our research assistants at least twice a week over the course of the 12-week study. And then the contingency management patients, they got the drug testing at least twice a week. They also received reinforcement for providing urine samples that were negative for cocaine. And then they were 12 months of treatment, and then we followed up with them at post-treatment, and then 6 months after treatment ended, and gave that whole battery of assessment measures. But we were specifically interested, we gave them all urine toxicology tests again, and tested whether or not they were currently using. All right, so to orient you to this graph, so we have the standard care participants are on the left side, and the contingency management participants are on the right side. Green is patients who reported having not engaged in any illegal activity prior to the start of treatment. And the blue is those who reported that they had engaged in some illegal act prior to the start of treatment. And the illegal activity could have been something that they actually got incarcerated for, but it also could have been just they disclosed, like I did this illegal thing, the police never caught me, but I did, I sold drugs, something like that. That was all kind of combined together. And then the outcome measure we're seeing here is proportion of negative cocaine samples over the course of the 12 weeks of treatments. So every time participants came in and gave that urine sample, we kept track of if it was positive or negative for cocaine. And this was the number of times they were negative for cocaine divided by all of the times that they came in. So how often out of when they showed up, they were negative. So we see across the board that the contingency management participants did much better than standard care participants. So here, higher is better. it was about 50% of the time that the contingency management participants were negative, whereas only about 25% of the time that the standard care participants were negative. And there was no difference for contingency management if they were engaging in illegal acts. So if they were the proxy for more impulsive, no difference if you were in contingency management. And also if you're just considering them to be more complicated patients, also there's no difference. All right, and then this is the follow-up. So this was a 6-month follow-up. This is just a one-off single urine toxicology test at 6 months. Again, we see that long-term follow-up. The participants in the contingency management treatment were significantly more likely to have a negative sample than those who were in standard care. Interestingly, those who engaged in an illegal act prior to the start of treatment, they were worse off if they got standard care than participants who had not engaged in the illegal activity. So there's something, some sort of maybe protective factor for not going out and continuing to engage in illegal activity if you're in contingency management. And then this is the change in illegal activity over time. So same still, higher is better. So about 86% of the sample didn't do anything else illegal. There was no illegal activity over the 6 months. So there was overall a reduction. So 26% at the beginning were doing something illegal, 86% did nothing illegal over the whole 6 months. So overall reduction, but we see that those who were in the contingency management treatment, so the blue all the way to the far right, were significantly more likely to not re-engage than those who had just the standard care. And if you weren't doing anything illegal, you really didn't start doing anything illegal, so that's good. Right, so overall, contingency management led to improved outcomes across the board. And there was a significant benefit of reducing subsequent illegal activity. And interestingly, so the big thing about contingency management is that you're giving this reinforcement for a specific period, so 12 weeks. And then there's concern that after you take the reinforcement away, people just go back to doing what they were doing. But this study found that for both substance use and illegal activity, even after you took that reinforcement away, people still continued to do better. They didn't go back to using, they continued to not re-engage. So limitations, future directions. So this is a retrospective analysis of data. So this was secondary analysis. This was not what the study was designed or set out to do. We had people self-report on their engagement in illegal activity, which, that self-report of anything has its limitations. We weren't going to tell anyone if they engaged in illegal activity. There was going to be no consequences unless they were disclosed homicide. So there shouldn't have been reason for them to not report, but they very well could have. We had no direct measure of impulsivity. So kind of set all this up as this is a proxy for impulsivity. This is a treatment we could use for impulsivity, but we're just guessing that these people are very impulsive. So be interesting to do follow-up studies where we're kind of specifically measuring and designing something where we can accurately appraise illegal activity engagement, as well as the mechanisms through perhaps which the illegal activity is reducing. So capture impulsivity in some manner at the beginning and over time and see if impulsivity does change with the contingency management treatment. Right. So overall, multidimensional model of impulsivity significantly related to gambling behavior. This second model, the acquired preparedness model that was developed in an addictive disorder sample, a substance use addicted disorder sample, also was predictive of gambling behavior. And what we expect about what will happen does relate to whether or not we engage. And then in this sample, this treatment-seeking sample of individuals on methadone maintenance treatment and with co-occurring cocaine use disorders, if you provide them with randomly assign them to contingency management treatment, they're going to reduce both their cocaine use, and if they'd previously been engaging in illegal activity, they will be subsequently less likely to engage in illegal acts. So some future directions. So Impulsivity has a whole bunch of things that we think are related to it and a whole lot of things that we want to continue to research. So one thing I just flagged as interest is the relation between gender and outcomes with risk behaviors and how it relates to impulsivity. I'm guessing a lot of people that know things about substance use and gender that are sitting in this room saying, like, she never controlled for gender, like, what's that about? Because we know that males and females engage in substance use differently, and males tend to be more impulsive. So definitely would be important to start looking at sort of how those things relate. So far, I've just sort of been interested. It's been like, oh, it's cool. It looks good across the board, but kind of starting to dismantle and kind of figure out precisely what's going on. Also, I've taken this. So the original battery to get these 3 dimensions was about 300 items, and I've conducted a study where I was able to reduce those items down to just 33. That was about as predictive as the battery of 300. Still needs a little bit more refinement and a little more work. But the hope is if we can have a short measure of multidimensions of impulsivity, it would be more useful to us in measuring different samples and more behavior. You're not going to give your methadone maintenance patient with a co-occurring cocaine use disorder a battery of 300 items. They're never going to be doing it for you. But 33 maybe we could get done. All right, so impulsivity sort of is this across the board measure of risk and increased engagement in behaviors has a lot of different implications. So impulsivity likely is present in all of the interactions we have with all of our patients. So it's possible, or I would hypothesize, and other people have hypothesized, that impulsivity is and failure to difficulties with self-regulation and distress tolerance is why patients don't keep coming to treatment. Because what happens with our treatments, and anytime we kind of, even us as individuals, when we try to make behavior changes, things usually get worse before they get better, or they certainly don't get better immediately. If you're coming in for a 12-session cognitive behavioral therapy intervention and you expect things to be perfect after day 1, 50 minutes of sitting with your therapist, it's probably not going to work. And those individuals who are more impulsive and less tolerant of distress, they have a harder time kind of withstanding those early changes. I think even like if you were to, I don't know, something simple like want to start flossing your teeth more often. You're someone that's never flossed your teeth ever, the dentist got after you, now you have to floss. The first month probably of flossing your teeth, it's going to not be fun. It's going to be painful. It's not going to be very reinforcing. The dentist isn't there telling you what a good job you've done. You may stop. You may quit before you receive the health benefits. So if there's something we could do to make the immediate sort of small steps and of engagement in therapy, if we could reinforce those, maybe we could get people to stick around longer so that the active treatment components that we know work so well could start taking effect. So contingency management has the opportunity for that. So possibly using contingency management as an add-on treatment to the things that we already know work well, to give people concrete reinforcement for early changes within their programs of treatment, and then we can fade it down. And at that point, the CBT that we're giving, we know that works, and they've started to hit recovery. So I've gotten to Johnson City. I think probably most of you are all familiar. There's the joint venture between ETSU and Ballad Health over Mountain Recovery, the methadone maintenance clinic up in, I think it's Gray. So they have concerns about patients coming in with a lot of comorbid substance use in addition to opioid use disorder. They have a program in place to help with the opioid use with the methadone or Suboxone, but how do we help these patients also get additional treatment for stimulant use disorders and benzo use and those type of things. So we're trying to talk, we're hoping that maybe contingency management could be a place there to be able to help specifically target things, co-occurring disorders that opioid medication-assisted therapy does not directly target. And this is just like a fun add-on. So behavioral addictions researcher, so I'm sure many of you have heard about the new proposed clinical diagnosis of internet gaming disorder. So it was proposed as like a research diagnosis for the DSM-5, saying maybe this is a disorder, we don't know, but like do more research on it. ICD-11, they actually decided, I think they announced in June, they're putting it in as a bona fide mental health condition called gaming disorder. So it's good to be an ICD-11. So I was actually, as part of my postdoc, I was part of the first US-based clinical trial for the treatment of internet gaming disorder, and hoping that I can do some more work kind of exploring that. I'm not totally convinced it's a bona fide mental health condition, having seen a whole bunch of these kids, but it's definitely a problem that youth and their parents are struggling with that it would be great to have some treatment options for in the US and East Tennessee. All right, so acknowledgements, thanks to my colleagues at University of Memphis. Some of the study collected data for studies 1 and 2 was completed at the Institute of Living up in Connecticut, and then my postdoc research was all at the University of Connecticut School of Medicine, UConn Health. Questions? Yes, sir?
What was the reward?
What was the reward?
In
In the methadone. So it's called prize-based contingency management. So what they do is they get, for providing a urine-based, a negative urine toxicology screen, they get the chance to pull a slip out of a fishbowl. Half the slips in the fishbowl are what we call good jobs. So they just get kind of a congratulations, you're sober today. Like, that's awesome. 20% are small prizes, or 30% I think are small prizes worth about $1. So they're bus tokens, small personal care items, candy bars, that type of thing. Then there's the rest are $20, so gift cards, small appliances, food items, that type of thing. And then there's one slip in every jar that's a jumbo prize worth about $100. And they often get gift cards for that, or larger appliances like air conditioners.
you're encouraging them to gamble.
Yes, so an exclusion criteria for the contingency management is you cannot have a history of gambling disorder. So that is an exclusion. So yeah, so it is. But we know gambling is reinforcing, so that is why we use it. The reason why the prize base is done is because if you want to do the treatment for one person using the level of, you can give them money directly, so like $5 for each negative urine toxicology sample, but it ends up costing about $1,200 per participant. With the prize base, you can get the cost down to about $300 per participant, which is a much better option for most clinics.
One other observation about the methadone clinic.
Yes.
And that you're providing positive reinforcement. But in fact, if their urines are dirty, then they face negative reinforcement and possibly discharge.
Yes.
And they will certainly lose their take-home meds.
Yes.
And they will be punished in so many ways.
Mm-hmm.
So that would differentially apply across those who are providing dirty urines and those who are not.
Yes.
Therefore, if you compare your results with the clinic as a whole, you're including the ones that don't have dirty urines,
Yes.
which biases the interpretation.
So some of these patients got discharged and they still were followed. So we had outside research offices as well that these patients, if they got discharged, still came to. So we had I think it was about 87% follow-up rate. So most of these patients, even if they had gotten discharged, we were able to still do our research intervention where we continued to monitor them and provide the contingency management, even if they were no longer, they'd been discharged from the methadone clinic. Additionally, we did not share the findings from our research trials, those urine toxicologies, with the clinic. So there was no direct repercussions for testing positive in our sample, our study, and then correspondingly getting kicked out of the methadone treatment. It would have been if they'd also been getting tested positive.
The biggest positive reinforcement that those patients have is the methadone itself.
Yes, absolutely.
It feels delicious.
Yes.
And once you are tolerant to the dose that we start you on, 30 milligrams or whatever, we increase it, which is also delicious. So discontinuing from that puts you in an entirely different category of person.
Yes. Yeah, and the number of people who were discontinued in this was almost none, as just, and I guess as side information. These clinics weren't actually urine testing people with any amount of frequency, and several of the clinics, they weren't worried if you were testing positive for something else. It wasn't a discharge immediately protocol. They had to do more counseling sessions. So, but yes, no, you were absolutely correct. Yeah, if you're giving the methadone, you're already giving contingency management.
Right.
But that type of contingency management does not work for stimulant use disorders. We have to do something else for the co-occurring stimulant disorders.
The bigger problem seems to be the benzo. And that's actually applied between the buprenorphine clinics, who, if they were to follow guidelines, wouldn't give benzos, but they give them more commonly.
Yes.
And the methadone clinics that don't. So it's not a level playing field in terms of the neurochemistry.
Yeah, and we don't, in these samples, some of these samples were even like more early 2000s, we weren't seeing the benzo use the way it is now. And also the population up in New England, this is like the Connecticut area, is just, they're really heavy cocaine users above and beyond anything else. What I've heard so far, I've only been in East Tennessee for about a month, is that the benzo rates in this part of the country are much higher than anything I've seen in the addiction sample. And that's even maybe above and beyond than any of the stimulant use concerns, especially because of the respiratory distress. You're gonna die quicker doing way too many benzos with your methadone than doing a bunch of cocaine with your methadone. We don't want them doing any of it, but we don't want them to die. Yes, sir?
One more thing that I've noticed, sometimes the patients with the addiction behavior, they do have this tendency to make all kind of excuse, like I'm self-medicating with alcohol or opioid or anything else. And I saw it in also gambling, for example, in lottery ticket. They would say, we are helping the college students, we are helping the, you know, all this good thing that comes out of the, so it's a challenge sometimes to really attack that kind of the mentality when it comes to the treatment of the addiction. So
yes,
all kind of excuse.
Yes, absolutely. So yeah, so every population in my studies has a whole bunch of excuses. None of the interventions or research I looked at targeted anything about their excuses. The good thing about contingency management is I don't care what you tell me, like either you're negative or you're positive, the end. Like you can tell me a crazy story about how someone put this drug in your drink and you had no idea, but I still don't give you the reinforcement. So it does pull that piece out. The gambling is unique as an addiction because I've never met anyone that will tell me, you know, if I just get high one more time, it'll fix all of my problems. But your gambling patients can say, if I go to the casino and I hit big, like all of my financial issues will be eliminated and my wife will move back in. And you can say, and like you can't say that it's not true. Like it's actually true. They could solve all their problems, and they're helping. Again, yeah, no one is saying, oh, if I buy heroin, I'm helping college students go to college in Tennessee. But if I buy lottery tickets, I am helping college students go to college in Tennessee. So there is different. It's different, and that's why I've been interested in kind of looking at these models of how it's the same too, because we've spent so much of history saying gambling is so different from substance use. And there is bona fide differences in reasoning and excuses and why you engage in that behavior, but there's also so much that is the same. And it gives you this kind of pure look at addictive behavior without having this upper or this downer on board.
Well, the same thing applies for patients that they do have a chronic pain, and
yes.
the heroin will alleviate that pain, and they will say, well, I have this back pain going on for a long time, that's why I use the Low-Pac, that's why I use the Percocet, but they don't give it to me.
Yes.
Now we come up with the methadone and the buprenorphine, which it does really help with the pain. And then we substitute those medications for the use of the opioid, for example. So there is some kind of the benefit on that one.
There's benefits from both of them, absolutely. No, I think of all drug use and all even any sort of risk behavior is a rational thing. I may not understand the rationale fully myself, but if we were to back it up and kind of do a chain analysis, it's a rational decision. We're not talking about people who are illogical in their behaviors, which is good, because if they were totally crazy, we could never help them. They're totally rational people. We can help them. We just have to figure out what it is that makes it tick, that allows us to make these changes. Questions?
Thank you.
All right, thank you.